Hello and welcome to this spring update for PCNs. My name is Alison Oliver and I'm a partner in the primary care team at Hill Dickinson. Before moving on to the main content of the session, I just need to outline some housekeeping points. The first thing I'd like to say is that this is a new platform for the speakers, so apologies if we have any technical hitches. We'll do our best to navigate our way through it. Your microphones are muted and cameras automatically switched off. So if you have any questions, please type them in the Ask a Question box and we'll either pick them up as we go through or we'll deal with them at the end. The webinar is being recorded and you'll be able to access the recording and the slides afterwards. We will be asking you for feedback as this helps us plan our future sessions. And at the bottom of the screen, you'll see a link to the feedback form, and it will also pop up at the end. We advise you to close other browsers and programs to maximize bandwidth for the webinar, and press F5 if you have any issues. So, as I said before, I'm Alison Oliver and I'm a partner in the primary care team at Hill Dickinson. I've been working with PCNs since their introduction back in 2019. It seems like a lot's happened since we first helped fledgling networks as they navigated their way through the initial registration process. And it's fair to say the journey hasn't always been plain sailing. Some networks formed quite naturally between practices that had already been working collaboratively. Others felt forced or rushed into relationships that weren't of their choosing. And then we've had Brexit, a global pandemic, reports in the media of increasing levels of patient dissatisfaction, and yet another reorganisation of the NHS with responsibility for commissioning primary care now resting with ICBs. Despite the challenges, many PCNs are doing fantastic work. So in this webinar, we're going to be discussing some of the main themes and issues affecting PCNs. This slide isn't an exhaustive list by any means, but shows just some of the main themes emerging from the work that we've been doing at Hill Dickinson. We won't be covering all of these in depth in the webinar, but I did want to highlight some key threads before handing over to my co-presenters. We know that integration will continue to be a major theme for primary care, and of course it's not a new theme. At a conference a couple of weeks ago in Leeds, the head of operations at Leeds Community Healthcare Trust, Sam Prince, mentioned that the earliest reference she'd been able to find to the need for integration between GPs and other services was in the Gilly report published in 1963. So it's certainly not a new thing. More recently, Claire Fuller's Stocktake looked at how we can accelerate integration and embed primary care at the heart of our new integrated care systems. And more recently still, the Hewitt Review recommended that ICBs should ensure better integration across the full range of primary care services. Another key theme for primary care is working at scale. And PCNs were formed around the concept that care is best planned and provided across neighbourhoods of 30 to 50,000 patients, small enough to provide personalised care, but large enough to be able to provide services that can't be effectively provided by smaller practices. The Hewitt Review recommends that the government looks at how to incentivise and support primary care at scale. Specifically, the review says that this could include practices merging, federating, working within PCNs, or GPs working as part of a multidisciplinary primary care division within a wider NHS trust. So the message seems to be clear that if practices want to retain some control over the planning and delivery of primary care services, they either need to merge, federate, or continue to work within networks of some description. Governance and employment of shared staff another important issue for PCNs. The fact that the network contract is commissioned as a directed enhanced service via the individual contracts of member practices means that PCNs don't have a distinct legal form that can employ staff or bear liability, and there's inevitably some risk for practices in relying on each other to ensure collective delivery of their obligations. So a large part of our work at Hill Dickinson is involved helping PCNs with their governance arrangements, often forming companies to support the work of the PCNs and limit the liability of the member practices. If the recommendations of the Hewitt review are followed, we're likely to see far more local control over the commissioning of primary care services and more services being commissioned at neighbourhood and place level. And we're already seeing ICBs starting to commission a range of local enhanced services via PCNs that extend beyond the period of the current DES. And these services are being commissioned via the NHS standard contract rather than via the DES mechanism. So this form of contract lends itself to contracting via a PCN corporate structure much better than the DES. And so I think we're likely to see more PCNs forming companies. It's fair to say that this is an uncertain period in the PCN journey, and we still don't know what exactly will replace the network contract DES from April 2024. We do have NHS England's commitment to maintaining Rs funding in some form or another, but we don't yet know exactly what the funding scheme will look like after the end of the current contract year. It seems likely that PCNs will need to continue to think about how to employ shared staff and make best use of the additional workforce funding. We hope that this webinar will provide an opportunity to reflect on some of the main issues and themes affecting PCNs and to think about the next steps for your PCN as we go through the last year of the DES. We've got some great speakers and I hope you find it useful. So in terms of what we're going to cover, for the next hour or so, we have a number of presentations. In a moment, I'm going to hand over to Helen Matthews, my colleague, who's going to talk about the new DES specification and what's new in that. Then Deborah Wood and Lisa Pennington from Moore and Smalley will talk about DES funding streams and financial and accounting issues for PCNs. Ruth Griffiths will talk about current trends and direction of travel for PCNs. Finn Robinson from Pure Physio will talk about alternative models for utilising Rs funding. And last but not least, Helen Holmes-Fogg from Redmore Health will talk about digital technology and how that can support collaborative working. So these are all going to be quite short presentations. We're aiming to finish at around 10 or 15 minutes past 2, and then have a discussion about the future of PCNs. As I said before, if you've got any questions or comments, please ask them in the Ask a Question box, and we'll either pick them up as we go along, or we'll pick them up at the end. So on that note, I'm just going to hand over now to my colleague Helen, who's going to talk about the new DES. Thanks, Helen.
Thanks, Alison. So I'll just start by giving you a quick overview of some of the key changes that have been made to the DES specification, which was published at the end of March. So NHS England have recognised in their covering letter to GP practices that they were keen not to increase the workload pressures for practices. So there would be no additional services required to be delivered through the DES. But there are a number of administrative changes to funding streams and also changes to the Rs scheme as well, which are designed to improve patient access. So patient experience and satisfaction is said to be sort of the key focus of this year's DES. And some of these changes have been met with some criticism in that they potentially increase the admin burden on practices. So there is a question mark at the moment over whether the new DES does actually relieve some of those workload pressures. So looking at some of the key changes, the IIF will be reduced from 32 indicators down to 5. And the 5 indicators are linked to flu vaccinations, disability health checks, early cancer diagnosis, and there's also an indicator linked to the number of patients that are seen within 2 weeks of booking an appointment. So now we have a smaller number of indicators to support a smaller number of key national priorities. And by reducing the number of indicators, we have funding being moved into the Capacity and Access Fund, which will now be split into 2 parts. So you've got roughly 70% being paid to PCNs as the continuing capacity and access support payments, and 30% is now paid as part of this local capacity and access support payment. And this part will be paid out by the ICB based on their assessment of a PCN's improvement in 3 areas over the course of the financial year. And those 3 areas are patient experience of contact, ease of access and demand management, and accuracy of recording in appointment books. And the intention is that by 12th of May 2023, PCNs need to have developed a plan to be agreed with the ICB to set out how they will be assessed on these indicators. And there is a separate guidance document which has been prepared by NHS England, which provides further detail on how that will operate. There've also been a number of changes to the additional roles reimbursement scheme, which has been designed to increase flexibility for PCNs. So some of those changes include an increase on the cap on advanced practitioners. PCNs will also be reimbursed for the time that first contact practitioners spend out of practice to enable them to undertake education and training to become advanced practitioners. And the scheme will also introduce apprentice physician associates as a reimbursable role. And the existing recruitment caps on mental health practitioners have also been removed. Again, the idea being to increase the PCN workforce and improve patient access. But as we know, it can take significant time to actually recruit and train roles. So it will take some time to see the impact of these changes on patient access. And we're also aware there are some concerns that whilst there may be additional roles in practice, that doesn't necessarily translate into additional appointments. It might just sort of offer up some breathing space for existing clinicians, for example. So there's definitely a question mark over the benefits of the changes to the R's scheme. And then, as with previous years, practices who are already signed up to the DES will automatically participate in the DES for this year, unless they opt out by 30th of April. So in summary, there are no changes to the services that need to be delivered under the DES, but there are a number of changes to the way in which PCNs can obtain funding and the roles that are available to recruit. So hopefully that was a useful recap to kick things off of some of the key changes before we move on to look at some of the financial issues.
Thanks, Helen. That was a really helpful summary. I haven't had any questions in the Q&A box as yet, so if there's nothing that anybody wants to ask at this point, I'll hand straight over to Deborah and Lisa from Moore and Smalley to talk about DES funding streams and financial issues for PCNs.
Alison. So as Alison has said, I'm going to be talking about the financial aspects of PCNs and also the funding that's going to be in the 2023-24 PCNs. So looking at the 5-year framework agreement, obviously introduced the PCNs and also to give funding clarity over the next 5 years for practices and also to address the workforce issues. So my first slide is pretty self-explanatory and you can have a look at that at your leisure. So that's just all the income that will be going into the PCN nominated bank accounts and also the PCN income that will be going direct to the practice as part of the participation payments. So financial issues. So clients have obviously fed back to us regarding any issues that they're having, particularly speaking to clinical directors and network managers about the issues that they face within the PCNs and collaborative working. So I've picked up a few of the highlights really. So firstly, we're 4 years into the framework agreement and when PCNs were introduced, it was never anticipated that in the next year that there was going to be a global pandemic that would occur and a vaccination programme that would test the NHS system as never before. So PCNs were 1 year into the proposed implementations when they were forced to deal with this, as you'll all be very aware. It did, however, encourage collaborative working very, very quickly, and the COVID hubs and collaborative working was a really great success for many PCNs. So economies of scale. So what are economies of scale? Economies of scale are when working at scale, efficiencies are attained by increasing either production of services and lowering costs. So an example would be sharing back office functions that would usually be done separately. So network managers are now being employed across many PCNs and that's really working very well and freeing up practice manager time, etc. Feedback from clinical directors is that the clinical director role was quite underestimated and obviously new strategic negotiating skills had to be learnt very quickly. Areas such as enhanced access are being now done at scale and feedback has been that this is working really, really well. Cash flow, are practices being paid by the PCN in a timely manner? So are you waiting for income as a practice, as obviously this is going to have a knock-on effect to your cash flow and maintaining the working capital within your practice. So this is for any services that you provided to your PCN or waiting for the surpluses to be paid out, which I'll talk about a bit later. PCN limited companies. So many PCNs are still employing the Rs under the lead practice or the joint contracts of employment models. We've encouraged many of our PCN clients to use the limited company structure to mitigate any risk, and the PCN limited company runs alongside the PCN and invoices the PCN to enable the salaries to be paid, and access to the NHS pensions was also made available under the temporary direction status until the end of March 23. Bank accounts for PCNs limited. So funding is obviously structured in the way that it goes into the lead practice, who's holding the bank account on trust for the underlying PCN practices. When you bring a PCN limited into the mix, that brings in a bit more complexity, which we've been finding some banks are a bit more clued up on than others. So when we have a PCN limited company, we're arranging for two bank accounts to be set up, one to pay and to receive the income, to pay the Rs, and the other one to hold the DES money on trust to facilitate the accounting and the audit trail and distinction of funds from the lead practices, which is sometimes quite difficult if it's maintained within the lead practice bank account, and also enables the network manager to access these funds and pay out, etc., what's necessary. Tax and pension issues. So VAT issues, as you're all probably very well aware, the PCNs were commissioned really in a way that didn't really work from a VAT perspective, particularly in relation to the staff employed to work across the practices, as provision of staff is usually a standard rated for VAT purposes. We've set up, again, the companies, and they have to be set up in the right way if they're employing the staff, to ensure that the shareholding is allocated to each of the participating practices in the network, and a cost-sharing group arrangement is then in place. And as this is a very complex area in VAT, we would recommend that you speak to your accountant to make sure it's been done correctly. Clinical directors. So when the PCNs were set up, it should have been agreed who was employing the clinical director, how they were being remunerated, etc. So there are various ways that the clinical director can be remunerated. There can be a contract of employment with the lead practice. Joint contracts don't work really, because if it's a partner, you can't be an employee in your own practice. And HMRC's viewpoint is that a clinical director is actually an office holder with needing to have pay-as-you-earn and national insurance deducted at source, even if they are invoicing on a self-employed basis. But this doesn't make them an employee within the usual rights, and I'm sure that Amy will be able to explain that in detail later on. So the clinical director is also an individual who's appointed by the PCN, and therefore we don't consider that a limited company is a viable mechanism for them to be paid, and IR35 regulations would have to be considered in this. And also there are VAT issues to consider with the clinical director as well, as HMRC views this as a VATable supply potentially. So pension and tax liability on the surplus. So obviously the income is the DES income, and as such is pensionable and taxable on the individuals within the practices, even if it's not actually directly drawn from the PCN. So even if the surplus is left within the PCN bank account. Most PCNs now we're finding are drawing the surplus as the Rs funding is fully reimbursed, and therefore it shouldn't really be an issue with withdrawing, even if it's enough just to account for the tax and the pension liabilities. If the accounts are being prepared by the accountant last minute, then this can sometimes cause a bit of a headache if the profit, the surplus, has not been accounted for when making estimates of what their tax or their pension liability is going to be for the year. So timely accounts are really necessary. So other accounting issues, again, that we found. So claims, are they being made by practices for income from the PCN? Are these tying up in with what the PCN accounts are saying? So do your accounts correspond to the PCN accounts? Or is sometimes the lateness of the information that you're receiving not really letting you check this in detail? Assets being bought by the PCN. So a PCN can't buy equipment other than for the practice or for the practices that are its members. And if it's being used centrally, then it needs to be shown as an asset on the balance sheet with a matching reimbursement. If the PCN ceased to exist and the asset is retained, then whoever is going to take the asset will have to agree a value to be paid for it, or if it's sold to a third party, etc. Deferred income. This is a bit of a thorny subject. So PCN accounts should be prepared in accordance with UK GAAP, and therefore income and expenses have to be recognised in the applicable year. Just because the income isn't spent yet doesn't mean that it can just be deferred and accounted for in the following year. So again, your accountant, make sure you have a specialist medical accountant who can advise with this. Software. So how to make sure that your PCN is separate to your federation lead bank account. That's really ensuring that your software can cope with that. So we would recommend that a cloud-based accounting system is being used, because we have had clients who provided us information in Excel format, which is sometimes quite difficult to follow. And cloud-based accounting, QuickBooks Xero, are able to have cost centres which really keep the income and expenses distinct from the lead practices. So we really would recommend that that's followed. So other things to consider, so the Rs, so sharing the Rs and location and monitoring of the Rs. So the target, as you'll be well aware, was originally 20,000 direct patient care staff by March 2024, then another 6,000 were added. So this would be to reduce the burden on the GPs and to also support 50 million more general practice appointments by 2024. So what has been achieved? Well, total number of direct patient care staff increased by 25,262 from March 19 to December 22. So it's well on its way to being achieved. There have been feedback from practices that we act for that estate issues are sometimes an issue. Practices are struggling sometimes to accommodate even their own staff, and having to locate these Rs sometimes is a bit of an issue. COVID did introduce the use of remote working, and that's carried on in some PCNs for use by the Rs if their services lend them to that. Supervision and mentoring of the Rs is easier sometimes if it's done more centrally. So say the federation is employing the staff, and appraisal and supervision then is done by the federation. We've had feedback that sometimes Rs working in the larger PCNs sometimes struggle more because they're across multiple locations and multiple practices. And also to remember, as you will all again be very well aware, that an Rs isn't a direct replacement for a GP. And again, we've had feedback that there is still a great deal of monitoring and input from GPs to ensure that this is working well. But obviously going forward, hopefully this will improve with more training. So post 1st of April 23 pension scheme access changes. So obviously it's been acknowledged that the NHS pension scheme is a valuable component of the total reward package provided to NHS pension staff, and pension issues access should not be an issue to the delivery of services. So prior to 1st of April 23, time limited access was provided to the NHS pension scheme to PCNs. And there was 8 PCN scenarios, which organised the way that PCNs were remunerating their staff and how they could gain access to the pension scheme. The consultation that's recently been done has now said that they want to provide permanent PCN access to the pension scheme for PCN staff who meet one of the 8 scenarios. If your limited company only employs staff and doesn't have a PCN DES subcontract or qualifying contract, there may be issues going forward from 1st of April 23, and we would recommend that you take legal advice to determine whether or not you need to put the PCN subcontract agreement in place so that your staff still have access to the NHS pension scheme. Looking ahead, I know we're going to discuss this in a bit more detail, and I know Alison mentioned it before, but the fuller stock take, obviously the vision was to improve access for the NHS, experience and outcomes for people and communities. And these were the recommendations which form a key part of what's going forward, and really to build on really what worked well locally for COVID, in the response to COVID, and building integrated teams in every neighbourhood to bring together these professional teams to provide better patient care. And obviously, as well, the potential merger looking ahead of PCNs to have a greater voice at place level as well. And also the shortage of GPs and optimal deployment of ours is a political headache and obviously very much in the news. So the government does need to consider ways of attracting and retaining GPs, particularly in the partnership model, and also how the PCNs can be used to support the Rs to make sure that they're of optimal benefit for practices and the wider system. We are all very well aware as well that 2/3 of GPs looking to retire in the next 5 years, 50% of GPs in the next 10 years. This might slightly have been mitigated by the recent changes with pension charges, with the lifetime allowance, etc. But there's still managing high demand for services and ageing population, again, which you'll all be very well aware of. So in conclusion, it's just a real need to build on what's been achieved in the last 4 years and ensuring that PCNs and primary care is at the forefront of this. And as obviously we would recommend that you use a healthcare specialist accountant to ensure that you can be helped to navigate all the complexities of the PCN financial matters. Thanks very much. Any questions?
Thank you, Lisa. We don't have any questions in the box as yet, but I'm sure we'll get some in over the rest of the presentation, and we can pick those up at the end. Do please put your questions in the box if you have any at all, and we can either respond to them within the question and answer chat, or we can pick them up in the course of the presentation. So I think we can now move on to Ruth, who's going to talk about current trends and direction of travel for PCNs. Ruth.
Thanks, Alison. I will do my best to say something sufficiently controversial so someone puts a question in. Oh, God, I thought I was good then, Colin. Something's coming already. Do you want to, should we pick that one up before I start?
Oh yeah, that's not a bad idea. So this is one for Lisa or Debbie at Moore and Smalley. Can you explain why you recommend 2 bank accounts for a limited company? I think maybe it was 2 bank accounts, one for the PCN and one for the limited company. Is that what you said?
But, no. We've been recommending two bank accounts. So one to if they are employing the Rs, so to receive the income from the PCN and to pay out the Rs, obviously the salaries. And then the other PCN bank account, as I've said, we're finding that many PCNs now are employing network managers who, if the lead practice, if they're not employed by that practice, are sometimes having difficulty accessing that bank account and being able to pay out, etc. from it. So to hold that on trust for the PCN practices, and then it just helps an audit trail as well. Debbie,
yeah,
I don't think else to add.
I'm here to help with the Q&A. Well done, Lisa, for the presentation so far. Just yes, there's two points really with the bank accounts. The PCN itself, if as a separate entity, should have its own bank account. The difficulty here is that we need to hold a group of funds that's representing the PCN DES in trust for the members of the PCN, and there are various ways to do that. It's quite difficult for the PCN members all together to become party to a bank account. I'm sure many of you will know that it's very difficult to open bank accounts. So to facilitate that, we suggest that if there is a PCN limited alongside the PCN, they open that trust bank account on behalf of the PCN and manage it for the PCN. So that will receive all the DES funding and manage all the expenditure of the PCN through that trust account. But the PCN company will, of course, need its own trading bank account for its own transactions as a normal current account, day-to-day business account.
Thank you, Debbie. I can't see that we've got any other questions coming in at the moment. So I will hand back to Ruth to talk about current trends and direction of travel. Thanks, Ruth.
Thank you. So in my session, my aim really is to talk through, as the slide says, current trends and direction of travel. I know personally I've done to death the presentations around the different types of legal forms that a PCN can take. So hopefully you can all be reassured that I will not be doing that again on this session. But if that is something that you do want as a PCN, give us a shout. Our details are there and we're more than welcome to come out and talk through the different forms. We're in a very fortunate position in that we speak to PCNs nationally. So what I wanted to do was look at some of the trends that we're seeing and the emerging direction of travel, and then finally finish off by doing a bit of a kind of mystic Meg, probably more septic Peg kind of view of where we think things might be going in beyond the final year of the PCN DES. So picking up on the themes that Lisa's just mentioned around the limited company model for PCNs, we are seeing more and more PCNs moving towards limited company model. As Lisa said, it is something that the accountants are encouraging, and again, it is something that we as the solicitors would push to many PCNs just purely because of the advantages it has over the other unincorporated trading forms for PCNs. The drivers have evolved over time for moving towards a limited company model. So one of the main original drivers was in order to manage that employment risk. So you house your ARS staff and employ the ARS staff through the PCN limited vehicle, so you can ring fence the associated employment risks. And that driver hasn't gone away and is still probably one of the main drivers for many PCNs exploring the model. For many, though, they're at a point where, having worked on a lead practice model, so where you've got the one practice holding the bank account and employing all the ARS staff, they've got to a point where that is no longer sustainable. So we've seen kind of year-on-year growth in the funding. We've seen growth in the number of ARS roles that are recruited through a PCN. And that's got to a point now where we need to kind of ring fence the associated risk and the admin and management of that element of PCN activity. And the PCN limited vehicle is an obvious solution. We know we've got the pensions access, and that pensions access being put onto a permanent basis, as Lisa mentioned. There's the obvious tax and VAT advantages, again, covered by Moore and Smalley. And another one of the drivers that we are seeing is there is a bit of looking over the garden fence, and PCNs are seeing that actually the neighbouring PCNs have moved to a limited company model. Now, we would never say do it because it's what everybody else is doing. But if we look ahead to what potentially is coming in the future, and delegation by the ICB to place, and the place looking to commission services locally on a neighbourhood footing, the PCN limited vehicle offers them an easy contracting solution. It offers them an easy lead provider to be able to deliver services across, for example, within an INT group, in an integrated neighbourhood team grouping. You can see how general practice through a PCN limited vehicle could be that lead. And if you've got one and your neighbour hasn't, you can see why you may well be able to secure that contract, whereas other PCNs who are unincorporated don't have that easy solution for place. So some of the key considerations for the limited company model, and I'll pick up here around this kind of 2 bank account point, because this is something that's often missed by people who have incorporated their PCN. People think my PCN is a limited company now, but actually you don't lose this unincorporated tier of the PCN, because the way in which the PCN DES is contracted, it comes in to the individual, it's an add-on to the individual practices core contracts. They then agree as a collective, so the unincorporated PCN, to utilise PCN Limited to, for example, employ RR's roles for us. So that would be why you would kind of talk about this kind of 2 pots of money. There's the one bank account, which is the PCN Limited trading account, where we've moved across an ask from the PCN DES that the PCN is doing on our behalf. The other bank account is effectively to reflect this unincorporated tier, that there is funding held in that second bank account, held on trust for us as the unincorporated PCN. What we are seeing, and with most PCNs who press the button to incorporate, is that they do it on a phased approach. And it was actually kind of something that we recommend. So to start with, what most do is that they utilize their PCN limited vehicle to employ the R's staff. So you have the two bank accounts, and the ask is only there to deliver effectively or to house the PCN staff. What that enables you to do is kind of phase over time how much of an ask is moved into the PCN limited vehicle. So you may, for example, and this is what a lot that we work with have done, is over kind of a 12 to 18 month period, look to kind of transition more of the PCN ask into the limited company. So if you look at the two bank accounts, and jump in, Lisa, Debbie, if I'm saying anything wrong here, but you would then start to see more of the money in the on trust bank account move across to the PCN limited as you increase the ask of PCN limited beyond just housing the R's roles for us. Now, with that comes the ability to manage at what point do we trigger the need for CQC registration through the PCN limited vehicle. So that phased approach will allow you to decide at what point you start to move regulated activity, so for example the clinical management and supervision of those R staff, into PCN limited, as opposed to it being managed on an unincorporated practice level. I've listed some of the key documents that you'd see there. Network schedules, which you should have for every PCN, articles of association. So these are effectively the governing document of the PCN limited vehicle. You have to have them, but what we do is replicate your agreed governance structures that you've got in your unincorporated PCN. So you're not creating an additional governance tier. The two should work hand in hand. The cost share agreement to cover the VAT points that Lisa's just mentioned, and then a subcontract, which basically reflects the ask that I keep referring to from PCN unincorporated to PCN limited. And that's the paper trail that Lisa and Debbie want to see, that moves the money from being held on trust for the unincorporated PCN into the PCN limited trading account. Looking at kind of the second trend is the evolution of this PCN limited vehicle. So it's looking at that phased approach that I mentioned before. So those who've already pressed the button, we're seeing them starting to grow and develop and mature their PCN limited vehicle. So effectively increasing what we're asking PCN limited to do. In most cases, we're pressing that button and needing to register with CQC through the PCN limited vehicle, because we are now delivering regulated activity through the limited company. We're increasing the ask and therefore expanding the services that fall under that subcontract from unincorporated PCN to PCN limited. With that, kind of touching on the two bank account points, we're putting more of the money in the trading account as opposed to the on trust bank account. So you're maximizing the benefits from a corporate tax regime that Lisa touched on in her presentation. Another thing that we're doing with a lot of PCNs at the moment is building this idea of brand identity. Again, this is kind of doing the horizon scan about what may well come next. And I'll look at this in a bit more detail with the third trend, because we are seeing some ICBs starting to move towards commissioning directly on a local footing with PCNs at a neighbourhood level. If you build that brand identity, effectively the PCN limited starts to look like a business in its own right. You're basically telling the system, we are here to be able to hold those contracts, we are here to be able to participate in those place-based discussions, and potentially even at a system level to be able to dictate ultimately how that funding flows back through down to a practice level. And if we look, and kind of some of the feedback that we're getting from clients is that they feel that the system is doing very little to protect that partnership model. So I'll look in a bit more detail about how we can influence what's happening further upstream to be able to protect core practice. So as I mentioned before, key considerations as you increase the ask and what it is that PCN Limited is doing is manage CQC. So what I always say to PCNs is you should always view CQC registration through PCN Limited vehicle as a when and not an if. If you're going to fully utilise and get the most benefit out of your PCN Limited vehicle, at some point you will need to press the button. And therefore, as the ask grows, so too should that subcontract. So what many are doing are moving towards, I mean, what the lawyers are calling framework agreements. It is, for all intents and purposes, still a subcontract, but what they're having is a kind of generic front end terms and conditions. This is how our unincorporated PCN, i.e. the practices as members, will work with PCN Limited. So generic front end, and then we slot the service specifications in. So as you increase the ask, with each new service stream that PCN is doing, Limited is doing on your behalf, you add a new service specification. So you're future-proofing that document and also reducing the amount of times that you have to get in touch with the lawyers. So a third trend, and this is kind of where kind of looking ahead to kind of the next two speakers that we've got, is how outsourcing can now be a solution. Well, I mean, it always has been, but how it's evolved as a solution for PCNs. So originally, outsourcing, when it came to kind of the ARS roles and the functions of the ARS roles, was a way of managing the employment risk. And a lot of the time PCNs would outsource to, for example, a host or a trust or an employment agency who would effectively provide them with bums on seats, those ARS roles. This has evolved, and we're seeing now kind of outsourcing as being more than just providing you with the person, but the full wraparound function. And that is offering a genuine offer and solution for a lot of PCNs. I mean, we've seen in the press about the underspend around ARS and some of the barriers that we're hearing PCNs saying for them to be able to fully utilise the ARS funding. You know, this idea that we want to recruit but we can't, or we've recruited and we just can't retain. So this idea, I think, again, Lisa touched on it, that, you know, they're an individual member who sits across multiple practices, so they don't have that collegiate atmosphere and peer support. So again, outsourcing not just the role, but the whole function is, again, potentially a solution for that. But also it's this idea of capacity within the PCN, within practices, to manage and supervise these roles. So again, a third trend is that kind of evolution of the outsourcing model. And then just finally, fourth trend, I apologise, it's a busy slide, but trying to kind of condense what the system looks like now on one slide is easier said than done. If we kind of think now where about PCNs are in the system, so on the left-hand side, I've tried to kind of, in a very high level, demonstrate the different tiers of the system and how general practice needs to seat itself around the table at each of these tiers. So in the table on the right, I've kind of touched on there should be general practice representation around the integrated care board. That representation is there to bring a general practice perspective. So they're not there as delegates of their sector, but they should be somebody who has been nominated by general practice to sit around that integrated care board. The same at place. So place is generally where we're seeing kind of federations or a collaborative, but there should be something across place that is there to represent and influence on behalf of general practice to ensure that the services continue to flow. So it's kind of the direction of travel of what we're seeing is that more is being stripped out of core. So what we need to do is ensure that we can support and supplement what is being taken out and get it back down to that practice level if we are going to support kind of this idea and the partnership model of general practice. PCNs will sit here at this neighbourhood level, and then obviously we've got the individual practice level. There are lots of difficult conversations. I appreciate it's easy enough for me to say that you have to work as a PCN to agree how you're represented at place, and then in turn cross place how you are represented around the ICB table. But ultimately, if we don't do this, we can't ensure that that funding ultimately will find its way back down. I think kind of if we're kind of looking ahead, I think for service delivery, a lot of that will be happening at a place and at a neighbourhood level. So ensuring that you have a robust structure at a PCN is key, so that you can provide place with that solution, as I mentioned previously. So kind of just condensing everything that I've just said there, is we are starting to see ICBs who are delegating to place, who are looking to be able to contract at a neighbourhood level. Where we are working with place to do that, PCN Limiteds offer a streamlined solution, and in a lot of cases you can see how a PCN Limited may take on and hold a contract not only for their PCN but potentially a neighbouring PCN who is not yet mature enough to be able to hold that contract in their own name. So whilst the system is not intended to create competition between PCNs, potentially you can see that is a direction of travel. Hence why I mentioned previously a driver for incorporation at PCN level may well be looking over the garden fence and seeing what our neighbour is doing. We are seeing general practice leading at place. So we work with an organisation that has an established, in this case it is a federation, an established corporate entity at a place level that has its governance linked into PCNs. So it has clinical directors from each PCN linked into its governance structure, so that when that federation attends place-based meetings, they can send what is a true representative of general practice. Again, like I say, there is some swallowing of egos involved in getting to that point. But if we don't get there, then we can't influence what is then the funding that and services that then need to trickle down to support the practice level. There is huge disparity between the PCNs that we work with. So we are working with PCNs that have gone from strength to strength. They are not only delivering the PCN DES, but they have, for example, been a rescue vehicle for a practice within the PCN footprint. So they've offered kind of a succession solution where there has not been anything else. In that circumstance, what that enabled was for the practice to be effectively kept within the PCN family, as opposed to introducing a new third party who was going to come in and potentially acquire that practice. We've got PCNs who are starting to deliver services on behalf of their practices and actually a wider footprint outside of the PCN DES. At the same time, we are working with PCNs who are still arguing over who their members are and how those members vote and make a decision. So the difference in the kind of the organizational development is vast. What will therefore happen at the end of the 5th year? We don't know for definite, but they're talking about ours funding, for example, coming in through core. So we know there's that continuation of funding, but there's the potential that that kind of PCN mandate may well be diluted. If that's the case, you could easily see how there will be those PCNs who can jump on that opportunity and those that will be left behind or fold. So, if I would kind of suggest that we are probably going to see fewer and larger PCNs going forward, a potential increase in unaligned practices or practices who are parties to PCNs, but PCNs have started to move away from that model, that kind of default model of equity. So a lot of PCNs started off with one practice, one vote, regardless of list size. But I do think difficult decisions have to be had to recognise kind of the level of participation that different practices are playing within a PCN in order for that PCN to be able to succeed and grow. I do think as well, I think there is, as you kind of look at that system, general practice does not have the tiers of middle management that the other providers have to send to all the various different meetings that are going to take place across that spectrum of the system. So we probably do, as general practice, need to be looking at effectively an emerging and an evolving leadership role taken on by people that effectively becomes their day job. So moving away from that kind of patient-facing role and being GP leaders within the system on our behalf. ultimately, I would say that needs to be funded by the system, because that funding isn't going to be coming from anywhere else. So there needs to be that recognition from the system that general practice needs to be treated and funded differently from the other providers. And then organisational development, I've touched on this before, difficult conversations. I think we do probably start to need to move away from that default model of equity, and the barriers that creates if we are going to kind of start looking at a system level and being able to ensure that we can drive that funding down to a practice level and preserve the strengths of general practice that I know a lot of GPs hold very dear.
Thanks, Ruth. We've had a couple of questions about CQC registration, and I mean, the basic principle is that whoever is providing the regulated activity needs to be registered. The CQC website lists the activities that need to be registered. So, for example, the treatment of disease, disorder and injury, and you need to analyse in each case what activity you're providing, is it regulated, and who is actually responsible for providing it. So in the case of a PCN company, if the PCN company is simply providing back office support to the practices who are actually performing the regulated activity, then the company probably wouldn't need to be registered. But if the PCN company is actually managing the service and responsible for delivering it, then there's a possibility it may need to register. We have also had some questions around the R's funding, but I'm suggesting, because we're running a little bit behind time, that we pick those up after Finn Robinson's presentation, because Finn is going to be talking about R's funding. So we'll come back to some of those questions then. So on that note, thanks very much, Ruth. We'll hand now over to Finn, who's going to talk about alternative models for utilising R's funding. Thanks, Finn.
Thanks very much. We'll go into it. Just on the CQC point regarding physiotherapy, so first contact practitioners who are physiotherapists. Physiotherapy is not a regulated activity, which is something we've looked into for years now. We've had multiple discussions with CQC around this, but actually physiotherapy itself isn't regulated, which is maybe worth recognising on that particular point, which is one of the sort of main R's roles in most PCNs. So I'm going to talk about specifically R's and models of employing R's into primary care networks, into primary care. And really my background is around physiotherapists. I've been a physiotherapist, been an FCP physio. I also work with Health Education England as a trainer for the R's role, so providing training for people to become supervisors, whether that's GPs or other AHPs. And I'll be talking on the basis of that experience. I'm very enthusiastic, so I'll try and keep to time and move through and hopefully answer questions at the end as they go through. So, you know, most people will be aware of the range and breadth and help that are out there in terms of the R's roles that can be brought now into primary care. I think the ones that have been most well taken up, when we look at some of the audits that have been done across the UK, particularly England, we're looking generally at social clinical pharmacists, first contact physiotherapists, paramedics seem to be the top three typically. Depending on the size of the PCN, the other roles tend to be increasing or decreasing depending on the, as I say, on the size. But there's an awful lot of roles out there, all of which require different peer support, different professional support. They're regulated by different professional bodies. So there is a lot to consider when we're looking at R's roles, and recognising the maximum impact that you get from the role is probably one of the most important things, what works well for your patient cohort. There's essentially really three models of employment. Direct employment, so you employ the R's member of staff, and I see there's been some questions in the chat bar there around employment, direct employment of our staff. Positives on that may well be that they're embedded within the team. We've seen some very good models of this in different PCNs. Challenges around peer support, training, HR, capacity, governance are significant. And in the role I do an additional role as an ambassador for HEE, for one of the training hubs, those challenges, particularly the governance, so roadmap completion, Health Education England's roadmap to practice, for the different roles, those being completed with a qualified supervisor. The debrief, the time for this sort of support can be significant. I mean, Health Education England recommends 20 to 30% of R's roles staff have non-clinical time. So 20 to 30%, sorry, of their time is non-clinical, which is a huge amount when you then consider you have to have someone supervising for an element of that non-clinical time. So that could be a GP or it could be another member of the NDT. In a smaller PCN, when you have got 1 or 2 of physio, 1 or 2 pharmacists, 1 or 2 paramedics, to create that peer support interprofessionally is quite challenging. The other model, which is very regularly used, is a third party, whether that's via a secondary care provider or a rehab pathway provider. Benefits being that they're linked to the pathways. But some of the challenges we see quite often is there's a split focus. So when there's an increasing waiting list, for example, on a rehab pathway, occasionally the practitioners can be pulled back into that pathway to try and manage that waiting list, or into secondary care. During COVID was a huge challenge for people in that situation where they were pulled back in to deal with the acute pressures, which is understandable. Also, as a third-party provider, independent providers, where the benefits may be that we are able to focus on the PCN more specifically. We haven't got that split element with other demands. But the integration challenges, particularly on the local pathways, are things to be recognised. And we, I work with an organisation, Pure Physiotherapy. We work very hard on integrating with all the pathways and collaborating with pathways. I think there were several things mentioned earlier on, which I've scrolled down, around the integration, not just with pathways, but with the wider R's role. So we're working together with the clinical pharmacist on deprescribing. We're working together with the social prescribers on trying to demedicalise and return people to community activities and less isolated, etc. The knock-on benefits with mental health, etc. So that integration across all the different models is crucial, and certainly something that we're very focused on. The third, and I would say quite a high risk option for ours, is locuming, the locuming model. I locumed myself 15, 16 years ago. In our situation, the benefits of rapid mobilisation, low commitment from the practice or the PCN, but the risk in terms of peer support, governance, roadmap, liability, etc., are significant. And I do sit on a panel where we review things that have gone a bit sideways. Some of the locum models of our staff is where we tend to see the vast majority of these issues coming out. So how is that person being supervised through a roadmap? How are they being debriefing? How is the integration actually occurring? And it's quite a challenging route to look. So when considering ours implementation, I'm sure everyone here will have hopefully elements of ours, if not a lot of ours. The scope of the role, so what we're there to do. So if I take physiotherapy as an example, up to 25-30% of general practice workload will be musculoskeletal. So as a physiotherapist, we've got an ability to deal with that as MSK specialists. So the impact can be significant, although outside of MSK, that is beyond our scope. Recognising the scope of the roles you have is crucial, because again, where things tend to go astray is if a professional strays outside their scope of practice, and then they're working in a potentially high risk situation. So the impact is understood in physiotherapy, pharmacy, paramedics, quite well understood. Also dietetics, mental health, wellbeing coaches, recognise that impact and how big that might be. Mapping that again against the demographics of the population to see what's the likely impact on our local demographics. Putting in plan a place to mobilise that and then integrate with the other onward pathways, but also the team within the PCNs is important. Then also, and something we often see isn't happening, assessing the impact. So looking at data, what are we collecting, what are you receiving as practices, as PCNs, to assess the impact on patients, perhaps on further pathways as well. And that would include patient feedback. The roadmaps to practice, which are a requirement for certainly first contact practitioners, whether that's physios, paramedics, occupational therapists, dietitians, etc. There are roadmaps published by Health Education England, which they are required to go through. And if you are CQC'd and there is a demonstration that no one is going through those roadmaps, then there is an issue that can be pulled up from CQC. So although physiotherapy as a profession isn't CQC, is not a regulated activity, the need to demonstrate governance is, and that is what the roadmap is there to do. So patient feedback is a requirement of the roadmaps 40 patient feedbacks per year in an MSK role. So whether that's paramedic, physiotherapist, and these things you should be receiving now. And the future development, how things look as things develop. We mentioned the integration with other R's roles. De-prescribing is a great thing to look at, working with certainly the MSK roles and clinical pharmacists and mental health wellbeing practitioners. That integration within the PCN is fantastic, but also integrating slightly further frailty roles, pain management, etc. Apologies, my clicker's not going across. Can someone click me across one page? Fantastic, thank you. And maybe want to just click through a few of these points here. Thank you. This is a particular case study. I was asked just to do a case study of a PCN that we work with. So 56,000 population. We were asked, they had 5 practices, quite a large geographic area. And the challenge of the PCNs varies, I think, greatly depending on the location. They couldn't look at a hub-based model for the AIRS roles because of that geographical spread. They had significant limitations, and that was discussed earlier on, the limitations on estates, and particularly in 2 of the practices. And the existing provision they had for FCP, which could be applicable to any of the AIRS roles, was 2 whole-time equivalents via an agency-type model where there was physiotherapists provided, but without significant support. And that was complemented with a 0.5 whole-time equivalent from a local trust. If we can just click forward again, please. Thank you. That's great. The issue they had was the actual utilisation, the recognition of the service, the utilisation of the service was pretty poor. I mean, very poor, really. The DNA rate was ridiculous. So a DNA rate of 27% is ludicrous. We would expect it to be around, well, certainly under 10% in primary care FCP services. They weren't getting patient feedback. Again, mentioned that's a requirement. It was very much a reactive approach to how the delivery was being offered. And by that, I mean, if there was a problem, they were waiting for the problem to occur before they then tried to put a solution in place rather than using data or patient feedback to anticipate how they could improve the service. So there was no improvement plans in place at all. There was significant integration with local pathways. Even though one of the, or 0.5 was provided by a local trust, they were unable to order imaging, for example. They were unable to provide injections because there was issues with the local pathway from that perspective. And it was a very intermittent service. Annual leave and sickness meant that they didn't have consistency. We were asked at the time to look at providing more face-to-face provision, more visibility from a practice point of view, so training for the reception teams, etc., work on that integration with the local pathways and get feedback from the patients in terms of how their journey has been and outcomes that they've received. Thank you. If you could click forward again, please. Again, review the existing support, looked at planning out the rollout, how that would need to be. This recognition that essentially reception teams were not familiar with what the FCP role really was. As a result, they weren't able to communicate that properly to the patients that were ringing up to come into the service or booking into the service. Therefore, the DNA rate was understandably high because no one really fully understood, or a portion of patients didn't understand the full benefit of seeing us as a physiotherapist rather than a GP. Now, we are there as an MSK specialist. That's all we do. So if you were offered an opportunity to see an MSK specialist, as opposed to a GP who's going to be looking at the more medically unwell, etc., they may have an interest in medically musculoskeletal, but they're really there for the medically unwell patients. We only look at musculoskeletal patients. So a bit more clarity around us in terms of what we're there to deliver, and that being very clear to the reception team makes a huge difference, huge difference. We then immediately set out collecting patient feedback and outcome data in terms of how we're managing these patients, and that then allows us to review how we're progressing, how we're developing services and change things accordingly. And then reviews is part of that. Thank you. We can go forward. And just click through these, yeah. So this is we're about 6 months into this particular PCN. It's not difficult. The point of this slide really isn't about our service. It's about what you should expect to get from an outsourced and even internal. If it's directly employed, you should expect a similar sort of thing. So imaging, we'd see nationally, we see about 34,000 patients per month in FCP physiotherapy in our organisation. And these are not unusual outcomes. You should be looking at an imaging request, for example, in under 5%. Opioids, we track to see if we can try and improve opioid prescriptions. There's been a slight reduction, which is really positive in this particular PCN. Referral to orthopedics, less than 1%, certainly less than 2% nationally is quite normal. Self-management over 69, 70% is quite normal. And these are things that just hadn't been considered. And very importantly, for this particular PCN, the DNA rate within 6 months has dropped to 9%. And that's just by putting sensible, common sense measures in place and being transparent and asking the questions of patients. Again, it's part of the roadmap, so it should be happening anyway, but also allowing the PCNs to scrutinise with the data we collect what's happening. And that can be done internally. So just looking at where you're sending patients, how many going for injection, how many going for medication reviews, etc. Keeping that data allows education to the R's roles to then improve them going forward. Thank you. Next slide. And these are the sort of levels that you would expect to see from a well-run. This wouldn't just be us. This is a well-run FCP service. With the vast majority of patients, top left, 90-odd%, that we see within an MSK FCP service, we shouldn't then need to get contact from a GP. We should be able to manage competently, and that would include onward referral to secondary care, to pathways, imaging, if that's appropriate. The vast majority of patients would be managed within primary care without even needing to be referred on, 87.6%. That's national. This is based on the 34,000 per month. Very few requiring injection, 2.3% here. And the patient satisfaction rates, I mean, if there's a good R service, FCP is a good example, the patient satisfaction is very high. And again, this is mandated by Health Education England's roadmaps to practice. So you should expect a lot from these elements. Next slide, please. So we discussed this, and this is something that's worth perhaps reading again as a summary, but really you should expect an awful lot from the R's roles. It is fascinating when I talk to different PCNs, different clinical directors around what is happening in their locality, and whether it's the timescale for a session, whether it's the information that they're receiving back from the FCPs. It's very, very, very variable, but you should expect a lot. It does sit with under the R's envelope. These roles are well paid for AHPs that have come across from different areas. They do need to be integrated, they need to be inducted well and supported very, very well to get the best from them, but the impact can be significant. And the final slide, please. So thank you. Just if you pop those ones. Next one along. There you go. So the different elements that, directly employed is fantastic if they can be well supported. It's difficult to retain them if they're not well supported. The turnover rate seems to be very, very high in many PCNs where they're directly employed. Plus, actually recruiting the people in the first place can be quite challenging. Quality with all three, I think locum is very, very hard to make work. Talking as an ambassador, I think is very hard. But certainly direct employment or third party can work really well, but it's recognising how to plan that out. And if you get that right and you get the patient feedback and you get the outcome data, the impact on primary care is enormous. I mean, a huge advocate of all the R's roles, but the reviewing of them done in a robust and transparent way is crucial. Thank you. You can final one then. Thank you for clicking through. Appreciate it.
Thanks very much, Finn. That was great. We have had a couple of questions in about R's roles and employment generally. So I'm going to direct them initially to you, Finn, but also Amy from Hill Dickinson, one of our employment partners. If you could sort of be at the ready to follow on from Finn. I don't want to spend more than a couple of minutes on these questions because I'm conscious we need to hand over to Helen from Redmore Health. But on the R's funding, we've got a question that says, although the DES encourages us to employ the R's on permanent contracts, with the DES only referring to R's funding becoming part of core funding from April 2024, our practices won't take the risk to employ until we have full details of this. Can you offer any insight or advice? And before you answer that one, Finn, if you could just hold that one in your head, we've had another one as well, which is, how do you have the flexibility to cover sickness and annual leave? So one is a specific question about how you deliver your service with the flexibility to cover sickness and annual leave. But the other one is a more general one about horizon scanning, and should practices be taking the risk of employing people on permanent contracts when we don't have precise details about what the funding is going to look like going forward. And then I would like Amy to come in on that as well after Finn has said his piece.
Thank you.
Thank you.
Thank you. Thank you. I saw one of those questions earlier. So the sickness and annual leave is an interesting one. The consistency is key. We were involved in the very early NHS England trials back in 2016. We recognised from then, if you have a long period of illness or a long period of time where the FCP model just disappears, the value to patients, the value to practice drops off very rapidly. So we as an organisation will commit to, once, if there is, we call long-term sick more than 2 weeks, we will cover it with another practitioner. Now we can do that because we're an organisation of 270 FCPs, and we've got a structure which allows us to do that. That's perhaps one of the benefits of a third-party structure as well. We can have in our support, Ruth talked about wraparound support, we can make it a bit more encompassing. That would include maternity cover, etc. So you are paying for a service which you are getting. The annual leave, again, we will look at putting in place cross-cover arrangements so that you have elements of cross-cover. Certainly where there's 2 FCPs, even if you were directly employing 2 FCPs, you could trigger it so they don't overlap at the same time. We're very proactive in managing that aspect for our teams so that the PCNs don't end up with a loss of service. I don't think we've ever had a PCN that's lost more than a week's worth of cover. So we work quite hard. It does take a bit of proactive planning to do that, but whether they're directly employed or via a third party, that should be possible. It's having that in the agreement at the beginning, and so that everyone's aware of how that should be structured. And the R's employment challenges, as I say, I represent Pure Physio, a third party. We've got a break clause so that there's no real long-term risk or liability to that relationship. So that element for us isn't significant. However, if you were looking at directly employing, that anxiety I think is probably fair. Although the iteration from NHS in March was that we should be trying to employ for long-term, but there wasn't much more meat on the bones, and Amy might have more to say on that.
Yeah, so if I could invite, I mean, we don't have any more information on the future of funding than anybody else has, so we don't have any particular insights on that. But I think it might just be useful to have a very quick input from an employment law perspective on insecurity of funding generally, because we also have another question which says, although we've got some assurances around the R's funding, what about the managerial roles that are funded through core PCN funding? So Amy, are you able to just very quickly give a very brief answer on those points, and then we'll hand over to Helen?
Yeah, absolutely. Thank you, Alison. So just a quick one from me. In terms of the sort of claims that would be made, if obviously there were people that were employed and then this arrangement needed to come to an end, then you would likely be looking at unfair dismissal claims, redundancy claims, which you need 2 years service at least to make. So I suppose for those that are already raising these questions, for example, like the PC manager question, it's going to be a case-by-case basis. Have these people already been employed? Have they been employed for more than 2 years? Is their employment likely to continue for more than 2 years to even give rise to these claims? For those that are sort of more hypothetically being asked, sort of, should we even be appointing these people because of the potential risk? Well, if you haven't appointed someone at this point, say in an R's role, and you're concerned about what will happen, I mean, yes, we know it's been headlined that funding will continue, but we don't know under what guise. If you haven't though appointed at this point, then it's unlikely that these people, even if you were to take them on, would have more than 2 years service. You might take them on under a fixed term contract for say a year, 6 months. It would provide you with the benefit of the service without potentially the liability and risk of a potential unfair dismissal or redundancy claim. So they're just a couple of things to think about from a headline sort of employment law perspective, if that helps.
Thanks, Amy. Apologies, we are going to have to move on. In employment issues for PCNs, we could have done, well, we have done whole webinars on that subject alone. So perhaps that's something we can pick up later. We do have some more specific questions in the Q&A box about Rs funding, and I'm going to ask our team to perhaps have a look at those. Finn, I think there are a couple you might be able to pick up and give written responses to. And we'll try and follow up with any questions that we haven't been able to answer. We'll try and follow up afterwards. But right now we need to move on, and I'm going to hand over to Helen Holmes-Fogg from Redmore Health, who's going to talk about how digital can support collaborative working. Thanks.
Thanks, Alison. Thank you. Okay, everybody, I shall try and take you through this best I possibly can. So just a bit of background. I have sat for 25 years on the delivery side of the world of the NHS. So worked around primary care networks since they first started, and also from a federative perspective, working in federations. So my perspective very much comes from how we deal on a service delivery clinically and from a patient perspective as well. So I want to focus a little bit around digital. And I think at the beginning, we need to make sure that we're really clear about what we're talking about. And there is a difference between digital and IT, and it does often get confused quite naturally. So technology are the machines, the software, the coding, the equipment, and this is the IT. Digital working is about how we actually use these things to change how we interact with our patients in the practice. So we're all about the people and the process first, and then the tech. So we recognise how the world of work is changing, and that technology is driving that change, and perhaps need to start think about them in terms of opportunities rather than threats. Because I know traditionally people sort of tend to roll their eyes around digital and think, oh, that's just too much hard work, I don't know how to do that. But actually, when it's done well, and I'll come onto some of those points, it's actually really helpful. So we're all patients in the NHS. We're all citizens out there wanting goods and services for ourselves and our families. And as citizens, you know, if we think about how we work at home, people will often say to me, I'm not very digitally focused. But I'll just sit there and say, well, you know, how do you book your holidays? How do you book your flights? How do you sort your insurance out? We do online banking. We book our cinema tickets online. We shop on Amazon and Next. You know, all of those things we do, and we do them not between the hours of 8 and 6:30 during the day, but the expectation of us as individuals is that that's available when we're in our PJs at night, perhaps having a glass of wine, and we want to be able to do that at any part of the day. So we do need to think about the changing world and the changing approach of people. And although sometimes that can be really frustrating from a practice or a PCM point of view, the reality check is that we as individuals, you know, we'll find ourselves, our expectations are starting to change about how and when we can access services. So that is a really, really big question. But I think the challenge is how we do it. And again, I'll come on to a little bit of that. So we do signpost patients to a lot of digital tech. NHS app is a prime example. And most practices and PCNs have got a Facebook page or, you know, an Instagram page and so forth. So we are starting to do that. But we use it. The bit that we're struggling with, because of everything that's gone before and the things that people have said, is that we're challenged with the time and the space to actually integrate the tech and to shape how we actually put that in place, because it isn't simply just adding a piece of digital solution in a pathway and then expecting it to work. We've got to harmonise that from the front end of the patient, how they see it, all the way through to the back end of how the clinicians actually deal with it. But there's a lot of assumptions out there, and some of these you can see on the page, you know, that it's so impersonal and it lacks human touch. And while digital healthcare does rely very much on technology, the important thing is that healthcare professionals are still and always will be the core of healthcare delivery process. So digital healthcare can actually enhance the personalisation of care by enabling healthcare professionals to actually tailor the care to the individual need and do that beyond the core hours. You know, it's only for young people. You know, the young people are, you know, tech savvy. And as a person who's very quickly going towards the age of 50, I suppose I could probably classify myself on the older range of that. But actually, 45% of over 60s actually have you know, smartphones, and they do online shopping and all the rest of it. So I think there is a tendency to think it's only for the young, and we will exclude those. And although, you know, we really do need to be very careful about it, patients of all ages use digital technology. It's only for minor illnesses, you know, the more complex stuff it doesn't work for. But actually now, with the advances of some of the connected technology and some of the other ways that we can actually manage chronic conditions at home, we've got technology that goes directly into the patient's home on their TV screens, and ways of actually managing them in that respect. So there are you know, a lot of use in it. And from a healthcare, you know, it's less secure. And absolutely there is risks associated with any technology. It's really important to note that a lot of digital tech is so well restricted from a privacy and a data privacy and regulation point of view that it can sometimes and quite often be safer than the traditional healthcare. And then finally, you know, it's going to replace healthcare. We talk about AI and automation and all the rest of it, but actually it doesn't. You can take a lot of that way, but the people matter, the clinicians matter. However, it's there to complement and not actually to replace. So obviously collaboration, massive. You know, Ruth talked about it before, and so did Alison and Helen. Collaboration has seen us through one of the toughest, well, the toughest period of time in the last, you know, sort of the pandemic, and having worked directly at the coalface during that period, I wouldn't have got through that, and neither would my colleagues if we hadn't actually collaborated. And the vaccination programme in itself was a massive, you know, sort of like a feather in the cap to say that it can be done under the right circumstances and for the right reasons. So again, trust, massive. I think a lot of the discussions that and the troubles that are around PCNs is usually a hearts and minds thing. We've got to have shared goals, and we've got to give each other a chance to shine, and other people. We're really good, aren't we, at being the sort of like the bottleneckers as managers or leaders within the healthcare system. We can often be that blockers, but there's so many people within your practice, particularly around a digital perspective, the younger ones, for example, who've got a keen interest in doing it, and they do it very naturally. They can pick that up for you and support you in it. It doesn't have to be you. So focus on the outputs and the outcomes rather than this sort of minutiae detail. It does take an element of bravery, but we don't need any more tech. I think we've been given lots of tech in the NHS, but now it's about how we actually use it and optimise it. So collaboration at scale, obviously for all the right reasons, and people have talked about this before, for all the reasons that are on this slide, it does give more opportunities. It provides safety and security. It's also really a sustainable way of supporting general practice into the future, whilst protecting that partnership model. And it optimises the workforce, but we've got to start to let go a little bit. Again, from an ICB perspective, it gives us a stronger place of negotiation as well. So for all the right reasons, collaboration is a great way to work and scale. And we've seen some great examples from alliances and federations where they've truly come from the right place and supported their PCNs to do that. So in these bubbles are all the sort of component parts of collaboration. And I'm going to focus obviously pretty much on the digital side of it, but all of these are component parts that wrap around the digital elements of provision in primary care networks that are still really important. So the structure, the finance that's already been talked about, the communication and engagement, which is a massive part of the new contract, and the Hewitt report that have said that communication internally and externally is so important. But just let's pause just for a second. If we think about what we've already got, you know, MS Teams and the capabilities, and I know people will probably roll their eyes when the screen's frozen or something's not quite working. But if you think about how we used to drive for, you know, potentially an hour's round trip for a meeting, and now we're there, got to be careful about our well-being and ensure that we've got breaks in between and we're not going back to back. But actually, from an environmental perspective and also the ability to get through things, it's a lot more sustainable, and we can reach patients in their own home as well. So it's a really efficient way of delivering care. Things like task management, you can do, you know, project management through that. It's integrated with the different apps that are available. And obviously it provides our colleagues in PCNs and the R's roles to be able to communicate with each other in a really quick and easy and regulated way. It's obviously from a safety perspective. There's things that we can do around this. So things like collaborative care can reduce you know, so much burden, but we've just got to, again, sort of like really do it in the right way. So there's loads of social media platforms. You know, we're sort of looking at how we can actually do things and how we communicate. So, you know, you've got to sort of look at all of the options that are available to you. Now, social media platforms can be a burden to some PCNs, but again, it's about doing it in the right way and how we do it. We can also use those to talk internally. We can create health and wellbeing for our own staff through private groups and private chat rooms for projects and sharing ideas. But obviously, you know, some of the more controversial things like TikTok have been a bone of contention. We do have to be really careful around that one. So yeah, absolutely, it's all about making sure that we're using the technology and social media platforms really, really positively. We can actually look at total or virtual hybrid working. So when we talk about estates problems, again, tech and digital use of how we use things, again, can really support staff in our organisations. That we, through the pandemic, we quickly turned around the ability of staff to be able to use laptops, digital staff passports to be able to move. And I'm not saying it was all very easy, but we did it. And what we have to do now is learn from the clunkiness and getting out the other side, and how we do that in a meaningful way. So, you know, you have got cloud-based HR virtual platforms. You've got the ability to actually use Teams to do the smart sheets, things like Monday.com, which is, you know, a really fantastic tools for some of these things. And then from a digital clinician perspective, telemedicine, brilliant. You know, we can do that, but again, you've got to have the governance around it, and all the guidance is out there to do that. But you can do that really remotely and do it well. You've just got to embed that really well. So I'm going to flick through these quickly. Resource allocation, again, you can start looking at workforce planning. You can use this to enhance patient engagement. A lot of the things that are in the current capacity and access tools are around how our patients feel about our services. From an R's role, we can integrate our professionals and we can actually do the sort of service delivery a lot more succinctly through that. And the technology that's available out there through the software through like Apex, Ardens, some Shape Atlas that's on the screen now, are really great tools that are easily accessible and have a ready-made sort of outcomes data-driven way of the world and the population health management that again is a digital focus, but it can actually get you there. Oh, I think someone clicked for me there. So from a service delivery perspective, you know, this is the key thing, and this is probably the one I'm going to leave with in the hop, skip and jump through the others. The one thing that we at Redmore are more often than not brought in to do, so we're not a tech firm, we come in and we support staff to embed it. So it's a looking around, so yeah, great, I want to do video conferencing, I want to do video group clinics, how do I do it? What we do is we come in as the experts and provide a lot of the digital and transformation lead R's roles as a service, as Finn was talking about before, because the recognition that it's such a massively wide and deep job description, and some of the skill sets that are in it are really challenging to get in an individual. The guys that we've got within the team all come from a primary care or a practice background, but have actually focused on a digital element of that and make it happen. So we look at operational flows, we look at clinical flows. How do you actually make it work? So a lot of the things in the new contract around assessment of need, again, that's the kind of thing we're working with different areas, from ICBs, regional teams, literally all the way through to individuals and practices to help them to do that. Obviously, we've got to stay safe. We've got to make sure that everything's, sort of kept aligned. So we've got to make sure it's accessible. So there's no good having digital technology out there for our patients and our staff if it's not accessible. And there's an awful lot of work that has to be done at a national level around infrastructure. You know, our ability to connect in and to interoperate and get systems connecting to one another is a massive challenge. And we've seen that through the PCN movement and some of the clinical systems are trying to understand. And we've talked about CQC and making sure that digital is very much, when we're delivering it, we really understand that we're not excluding the patients and it's the right thing to do. And then again, from a right thing to do, the ethical considerations that are around that. So take home points really quickly. Digital systems and devices are enablers, they're not magic wands. You have to reshape and harmonise your people, your systems and your services to optimise them. Working collaboratively in a digital capacity does require adaptation, but think about the how, not just the what. Digital champions and digital literacy, we do loads of digital champion training, and we've absolutely seen that when they have them in their areas, there's a massive uptake and it's a lot more succinct. But then slow down to speed up, give yourself the time to think laterally and longitudinally about how you're actually going to bring these things in, because it's not a knee-jerk reaction, it's actually embedding them so that they're there for the future. And I'm going to stop there because I can see Alison looking and I know I've gone over time.
Thanks very much, Helen. That was great. We are actually now at the end of our allotted time, so unfortunately we're not going to have time for any further discussion, but we do really welcome your feedback, and you should get a pop-up inviting you to give that. You will have access to this recording and also to the slides, and on the slides are the contact details of all the speakers today. So do please feel free to drop us an email if you've got any further questions. And if you'd like us, please give us your feedback about whether there are other topics that you would like us to run webinars on, because I feel like we could have talked about any one of these topics in a lot more detail. So if there's anything particular you would like us to revisit in more depth in a future session, then please let us know and we'll do our best to assist. I'd just like to thank our guest speakers, Helen from Redmore Health, Finn from Pure Physio, and Debbie and Lisa from Moore and Smalley. And thank you to Ruth and Helen from Hill Dickinson and Amy for being on standby for the employment questions. And thank you to everyone for your time in attending this session. We hope you found it useful. Thanks.